So what are some of those other simple things we can do? We've already talked about, suction is probably underutilized, and
Oxygen.
I'll even go so far as to say that for whatever reason, and we got to fix this from a teaching perspective, but like I've watched people come unglued when you hand them a whistle tip, rather than a Yonkow. It's like, what do I do with this? What do you mean, what do you do with this? It's the same thing. It's a little hose, right?
Yeah, you just suction them.
But,
oh,
yeah,
really?
I've watched. So it's something.
I remember their
we need to work on. But
cricoid cartilage isn't nearly as formed as ours too.
It's
You might
not,
need the.
Yeah, it's like the pediatric airway. I feel like it's
like a cone.
It's like
almost.
a cone. It's like a cone, and the cricoid cartilage is like the most like flexible part. It's not really strong. So
It's almost like two floppy
to protect
tubes
it's
back
floppy,
there.
it's not really strong. So it's definitely like a little bit more difficult, like to protect the airway of these kids. It's very different.
I want to get back to that oxygen thing and
Yes.
the basic things we can do, but you said something there that probably is worth discussing here. Is the conical shape of a kid's airway.
Oh, you're going to talk about ET tubes?
We're going to talk about ET tubes because that was a perfect lead-in.
Okay.
It's a perfect lead-in for that, and we can't skip over that. The trend as of recent is to use cuffed on everybody and rather than
But then
than
it went away
uncuffed.
for a while, and then it came back.
Where are we at with
I think
that?
we're now at cuffed.
What is
We're using cuffed on pediatric patients. I remember when it was we did do from cuffed to like uncuffed. Obviously, if you're concerned about severe edema, then you would probably use uncuffed. But in cases, we usually use cuffed.
Use cuffed.
And just make sure there's no leak.
So
And then you're okay.
And if there was, we inflate a little.
We inflate a little bit more.
and I think that's the important part that we need to tease out of here is a little bit,
inflate a
right?
little bit
It's
more.
Well, you don't want to cause tracheal trauma.
You don't want to
is
exactly.
We don't want to hyperinflate.
Yeah, you don't
cuff
wanna-
to seal, right?
Mhm.
It's
Yeah.
cuff to seal.
Cuff to seal.
How many
just
times
enough
have
air to.
you gone to your nursing home patient and they're intubated and you reach and feel the cuff and it's so hard. It's like
Trach patients,
Too hard.
like
really.
trach patients on a
Yeah,
ventilator
it's-
with no pilot balloon hanging
you,
off.
you
You're
stick
like,
the 10 cc
I have
syringe on there and it
Oh,
goes,
dear. And then it just comes.
and then you do it
out.
again and it goes, oh.
but that cuff to seal thing's important. I think it kind of gets overlooked or not talked about if we're going to make this transition. And I think most people have at this point have just put straight cuffed everything on our trucks because it makes our lives easier.
I thought we did.
Also, we have. That also means that maybe you have to go a half size smaller in some cases to get that size of cuff in. But if it seals up and you're getting good ventilation, you don't have to bring up the cuff.
You don't have to bring up the cuff.
And when you do, sadly, I know you and I strongly work against this, but there's especially the adult population, right? How much air do you put in? All of it, right? It's full 10 mL.
There's actually a calculation out there.
You certainly can't do that with a piece tube, and we need to make sure that mindset is out there. Is you're just going to put enough in. That might be half a milliliter, 2 milliliters, just enough to seal it up, right? So you're not getting air coming out of the oropharynx.
So to lead you to the question a little bit, when do I know that I've had enough air in the cuff, and when do I know that I need to put any air in the cuff?
Fair question.
That's a fair question. So when do you know you've had enough air in the cuff?
When
So
the
usually
plunger
just
shoots
seal
back
it.
across the room.
We've never had the plunger shoot across the room, thankfully. And we usually put about 2 to 3 cc's in. Maybe a little yank, maybe just a little, and that's fine. And then we just tape it in place. You have your capnography, making sure that you get your end tidal in place. It's yellow. You're good. You're in place. But we've never, that's a good question. But when do you know it's like really, like if you've put in too much, you're saying?
Or any at all. Why would I put any air in it to begin with? And what are the signs I would look for to know that I need to add air to it?
So if there's significant edema, because when you are intubating, you can visualize it. So if there's significant edema, for me, that's usually what I do. I just gauge it. So if there's significant edema, I don't put in a lot, maybe like a cc of air, if that. And I just do a little, like not even just like a little pull, and then I'm like, okay, I'm in, and then I'm good, and then I tape it. So I've never had an issue with that. Like Scott said, if you put in a lot and then it plunges out, then you're like, oh, holy, yes.
Then we just tear up your paramedic card in front of you, right?
Metric. So I've never really had an issue. Obviously, if there's a leak, so we do auscultate to listen, and if we do, And if there's a leak, you can kind of hear it. You can hear the swish, and then you know that you definitely have a leak. And then you can go back in and put some more air in.
So you're saying be good with your stethoscope?
Oh, definitely.
I think there's this...
Your pediatric stethoscope.
Yeah, correct. Yeah, correctly sized.
Well, yeah, you don't necessarily have to have a pediatric stethoscope. Is that a joke?
No, I just think some providers will kind of going back that, well, this just works for all. And it's, I think we'll talk about it on equipment, but I mean, that's a little bit of a pet peeve of mine, especially like when teaching. It's like, I look at this like a specialty. You know, most ambulances, I'm sure ours is no different than yours. You know, we have a specifically designed bag completely dedicated to pediatric patients, you know, for that reason. So it's like, use the proper equipment. We've spent thousands of dollars ensuring that we have the appropriate equipment, and spent, you know, a lot of money on a pediatric stethoscope, just like, you know, Certidose, other equipment that is for a pediatric patient, for that specialty.
Like your Mac blades when you're intubating, because those are, I feel like those are helpful if you think Millers are helpful. But for the little ones, you know, the epiglottis is like posterior, your larynx is anterior. You really want to get that epiglottis out of the way. So you want to use like you want to use the, what am I saying? No, did I make that? So you want to use the Miller blade, the straight one.
Blade,
yeah. And then the Mac, when they're a little bit older, I think like 10 and up, you can use the Mac, but.
And to your point, that's one of the bags that we need to get out more often, because generally when you do your monthly squad check, that's where you're finding expired equipment, because we just don't do it often. So it needs to be reviewed more and more, but that's the equipment we're going to need.
Yeah. And you do your checks monthly?
It was daily, but then every month or every week there's a different check as well. And that's when things get kind of micro.
Dumped out, really dumped out and gone through.
Good. We do that too. But I agree. I think it's more of a... it's good to have just like skills. You know, I think the lectures that you make for us, you know, like I want to say it's like a couple a year, like Caleb said. You know, I think the education is there and it's phenomenal. And I think we always have to remember in pre-hospital we have to bring the hands-on, just because
we do.
You know, we're gonna intubate a ton of adults. Yeah. It's gonna happen. We're gonna have plenty of you know, cardiac arrests. Unfortunately, we're very proficient in that. But it's like, hey, when have you opened the bag and then said, okay, this child measures this on the, you know, PD tape, Broslow tape, Certidose, whatever tape you're going to utilize. You know, what size, you know, do I need a Miller? Do I need a Mac? What size blade do I pick? How do I do that? Then, okay, let's intubate this child. Everything. Or, you know, the mannequin is what I'm talking about. Sure. But, you know, I think the hands-on skills, incorporating it with the education piece, really builds on it. And I think that's huge. So you really have to get those bags out more. I agree. You don't want to be the first time to open it at 3 a.m. and I'm like, okay, I need the orange pouch.
Well, then you open it, you see the yellowed tubing and all that.
That's.
I do appreciate the skill stations that they have. You know, I do the education piece, but every time they ask me to do like a symposium or something, like I come to you guys and so on, I enjoy it because I'm like, okay, I can talk for an hour, you know, 45 minutes to an hour, and then I can have a skill station, because that's where like it gets really interactive, and you know, people have questions and things like that. You want to, you know, like you said, you want to be proficient. You want to practice, because you guys don't see this a lot. So I want to practice, which, you know, I feel like is great. It helps.
Circling back to your previous comment about stethoscope, I think there's this reluctance. In the EMS world, is like stethoscopes are meant for listening to lungs. And nothing else, right? And that's all we use it for. And,
well, they told us to stop listening for carotid brutus.
Right, rather than listening, you're talking about, you know, listening for a leak or something. You might appreciate that only with a, you know, a stethoscope, or really getting down close to the patient. Things we wouldn't.
Have you ever put it in the patient's ears and talked into it?
I have not.
I saw that in a textbook.
You saw that in a textbook? Can you hear me?
Can you hear me?
But you know, we get settled into such a finite routine sometimes, and you know, I can remember I had it was my I didn't know what I was dealing with initially. I think I was an advanced EMT, intermediate EMT at the time, you know, at the beginning of my career, and we were trying to figure out. This guy was just leaning forward. He was drooling. He was an adult patient, right? And like, what's going on? But he's talking to us, and we're listening to his lungs, and finally we started to listen, swallow, and we were listening. And it was an esophageal obstruction. We
been there.
I was going to say
never. I had no idea. But we were just like working through the problem and moving. And it's like, oh, let's use the stethoscope for other things.
But that's being a diagnostician. That's
correct. We were building off that, right? And we finally like, well, must be something in his esophagus, right? But the point there is it's not just for lung sounds. You can use it all over the body. You bring up a good point,
right? Yeah, because you have upper airway and lower. Very good point, like you said.
Absolutely.
When you're using your stethoscope, upper airway, lower airway. Lower airway, yes, your lungs, but then upper airway, you have things like croup, and
Right.
there's some foreign body obstruction, which is the most common. I think it's the most common accidental cause of death in children. Yeah, in little ones, in toddlers.
Scans,
yeah, in toddlers.
If it fits, it ships.
It ships, yeah.
If it fits, it includes. So anyway, back to the simple things we could do. We talked about suction, and you started down oxygen before we digressed into endotracheal tubes and plungers shooting across the room. But oxygen.
Yeah.
Simple, easy.
I'm a big fan of oxygen.
Yeah, of course.
Putting them on oxygen, putting them on a non-rebreather. Yeah, I definitely.
Do we have the same worries in the kiddos like we do the adults? I mean, is there too much for our routine transport?
I think if you're putting them on 100% non-rebreather in a little one, if they're starting, I would say starting under 90% and putting them in 100%, I don't think that's too much. No,
for our usual transport
kids. Yeah. Obviously, the things to look out for. This is where past medical history is important, right? So if you have a child, for example, who the parents told you, is maybe like a congenital heart, had surgery or something, or has a congenital heart condition and hasn't had surgery yet, maybe. And, you go there and maybe they're still a little cyanotic. I know the first thing to think, gosh, they're cyanotic. I need to put them on oxygen right away. But this is where you ask the parents, like, what's their baseline?
What's normal?
What's normal? That's exactly. You want to ask them. And this is where past medical history comes into play when you're getting your history, because you want to know. And if they say, their baseline sats are like high 80s and the kid is in the high 80s, okay.
That's normal.
That's normal. Bring them into the ED. You don't have to, put them on 100% O's.
Maybe some blow-by or
maybe
just
some blow-by.
Slight supplemental.
Yes.
Right?
Especially with the congenitals and that, though. I mean, the parents are going to be way more educated than I ever will be. And you have to be a humble person to sit there and eat that.
Right. But even for us in the ED, you have
let them explain it. I remember years ago I was on a seizure patient. And I was telling the mom, I said, I know seizures better than you. She's fine. And the mom said, no. She humbled me very quick that day. I was very young at the time. Yeah. And ever since then, I was like, she's right. She's dealt with this kid's whole life.
Correct.
I need to take her word for granted. And I felt so bad about that afterwards. But I humbled up quick.
Yeah.
But listen to them.
Yeah.
Pick their brains. We had a couple POTS kids that I had dealt with for a long time, and we got to know them pretty well because we were there all the time.
That's a difficult one to diagnose.
We talked to the parents. Yeah. The parents would tell you they need fluid, put their legs up, and guess what? It fixed them. It was just talk to them. A good parent will be involved.
Well, I think the other thing too, from the special needs, like if it's a special needs child, like I can think of, we have one case that we have a special needs child that lives in our community, and that's the first thing we have. One provider will look at the child, the other provider's talking to mom. So what changed today? What's going on? I mean, all of us are familiar, but just the amount of history and knowledge you get out of mom is huge because she's that child's primary caregiver at home instead of essentially being in a facility. And then the other things too that I think sometimes overlooked, to your point, is we always want information. And I think the biggest thing is when they're little, especially, infants in those first, even, 1 to 2 years, the child's going to the physician. It's going to their pediatrician on regular visits all the time. So when you walk in, and what's the main thing I want as a pediatric patient, besides the history, is going to be a weight, right? And I think we overlook that. And it's like these little ones go to the doctor a lot. So mom usually can rattle that off.
Mom
we were at the doctor a week ago,
and
they weighed this. Boom, go. And then you can convert it to kilograms.
For us with kids. And
help.
I've said it before on one of our podcasts that even phoning dispatch on the way to the call in some cases, hey, ask mom how much the patient weighs, and let's say it's a seizure patient. I can just write it all out real quick, convert that easily, and be ready.
Yeah.
Get your chart out. Get that turned to the right. Yeah.
And
response off.
He mentioned seizure, and you were talking about oxygen, and I feel like that's a good for you to just talk about seizures because it's one of the most common calls we get in pediatrics, especially for some like febrile seizures. And a lot of times by the time these kids are in the ER, because they get fevers, temperature goes super high, the rate of the rise of the temperature, and then they seize.
Yeah.
And by the time, EMS gets there, the kid has stopped seizing.
Sure.
Obviously, if it's a prolonged seizure, that's even more concerning. But they've stopped seizing. But it freaks parents out, freaks them out completely. And the one thing we always say with seizures, even if it's like an epilepsy child and you're coming in, oxygen, please. Oxygen. Because if they are hypoxic, it can cause brain damage. Yeah. It can. So oxygen, please, yes. If they can, they can get postictal, but you want to check those O2 sats. You want to make sure they're satting okay. Because if they're not, then you're in trouble.
And if they're truly status,
please bag status,
them.
Exactly. Yes. You want to be calling Med Command. You want to be talking to us and,
bag them while you're getting your drugs. And,
right.
And I like to try to, unless I'm out in left field here, I like to try to obtain a blood sugar during that time too. So in that postictal phase, so as we're ventilating the patient, you have that child in the kind of limbo phase where they're not going to be fighting you, they're not going to be difficult. I can obtain that blood sugar as well, and then I'm not going to cause that, the child to be more anxious because they're in that postictal state
that's
too.
A good point.
So that's one of the teaching points I think we try to push to.
That's important because hypoglycemia can cause seizures too.
Of course.
So if they are already having seizures, even if it's not secondary to that and they are hypoglycemic, it's going to exacerbate it even further. So that's a very good point. Yeah.
If they were already marginal, you just burned a bunch more off. Yeah. Sure. Now you made mention to congenital kids, right? And turns out they're out in the world. They don't. Sometimes they leave the hospital with known, right? They're out. Sometimes they leave the hospital with a known, let's say a septal defect or something like that. They don't always just stay at the hospital.
Yeah.
And that's something that to your point, we might get a call on, and of course could be. I think we developed this this baseline acceptable comfort level with EMS with kids, and then there's the chronic kid or right, and then that's really where
the kid has, because you see that with adults, they have multiple chronic conditions. This is something you see, but with a child with multiple chronic conditions, yes, it can get a little bit cumbersome. It's a little bit more challenging. Yeah.
But to your point, why are some of those? Let's just talk about septal defects for a second, and that's kind of near and dear to me. My niece was a Down's kid born with both an atrial septal and a ventricular septal defect. Right? They went and they fixed her, and she's great today.
Yeah,
but I certainly, as we're talking about this, I certainly can remember constant pulse ox monitoring while she was resting. Right? Absolutely. And she was always dusky. Right? I'll let you talk about what's going on there and why they're dusky and why we shouldn't be panicked about it.
Yeah.
Or where we should be panicked about it, I guess.
I mean, there's some of them where we shouldn't be...
Are they mowing the lawn?
Crazy.
Every time.
Of course they're mowing the lawn.
There's some of them. I mean, most of them, we don't want them dusky. I don't think there's one where we necessarily want them dusky because duskiness also lets you think that their circulation isn't great. Yeah. So should we be careful with the way we hydrate them? Yes. Should we be careful with their oxygenation? Yes. So you were talking about ASD and VSD. ASD is just an atrial septal defect, right? So the septum right there in the atrium, there's a defect there, and that's where you would have some shunting of blood, basically from the left to the right, as supposed to be from the right to the left to the rest of the body. And VSD, just ventral, kind of like the same thing. Some kids with VSDs and ASD do just fine. I actually know someone who she just had it repaired. I think she was a teenager when she had it repaired. Oh, right. It all depends on your septal defect. How bad is the defect, right? Okay. So with these kids, actually, these are the kids you do want to put on oxygen. You want them on oxygen. You want to give them... you want to kind of help their preload. So you want to give them some fluid. So these are the kids I would tell you if they're dusky, they're having signs of shock, you want to give them fluids, you want to give them, you want to put them on oxygen for sure. And if you have an ASD or VSD kid that, is having symptoms like that and they're shocky like that, then those are the ones we kind of want to do surgical repair as soon as possible.
More urgently, right?
More urgently.
Yeah, and those are the ones that we probably shouldn't be taken to a community hospital.
Right. Now, there are the scary, scary ones like the hypoplastic left heart, where the left heart, basically, the left side of the heart isn't there. And those are the kids who kind of they're born, and then they start, as a resident, we had one, and you will never forget something like that, because these are the kids who are born, they're fine. So you have a shunt, which is called like your PDA shunt, which is where your blood goes through as a baby. So when you listen to a baby's heart, it goes whoosh, 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 whoosh. So that shunt is basically what keeps them alive in these kids who have like these congenital heart defects. But if that shunt closes,
it closes up, right?
Or you are in big trouble.
Yeah.
Or you are in trouble. So then, oxygen, but really what saves them is prostaglandins, really. And these are the kids, put in an IV, start giving them preload, putting them on oxygen, bringing them in, and on x-ray, a lot of times this is not going to be diagnosed in the pre-hospital setting.
Right,
Even for us, like it would be an echocardiogram that would diagnose this. But if you look at an x-ray, because the heart is working harder to pump blood, you will have a baby's heart is just huge on the x-ray. You're like, oh, no.
Right, this is not right. Yeah.
This is what you're like, oh, this breaks my heart. We start prostaglandins right away because you need that, you need that PDA, that shunt open.
Open, right.
Whereas in other kids, you actually want
it closed, right.
You want it closed. You want the opposite, right? So there's some of those where, you want that.
And we talked on some of the chronic kids and the some of the common respiratory stuff. What about like some other common things like anaphylaxis? I don't. We've got poisonings on here, but I think to your point, let's come back and do poisonings because we probably could. We probably could do 2 hours. We got to put her and Jordan across, and Dr. Singer across, and we could have just a toxicology. We'll step out of the room.
That'd be wild.
Yeah.
One of your CEs hit it on the head really great with her first strawberry one. And that one stuck out to me. So.
Yeah.
What was that?
So
I don't remember.
I had a case where I said like he just got his first strawberry, and then there was a photo. So the question I always ask is, what is the difference between an allergic reaction and an anaphylactic reaction? Like what
singular versus multi-system.
Exactly. Sure. Singular versus multi-system. Singular system would be like angioedema, meaning like swelling of your lips or something. Singular would be just skin involvement. Your skin is an organ, right? So would be like hives on your skin. But when you're having multi-organ, like 2 or more organs, so let's say you have hives, and then I always teach my residents, and I always ask like other things like, did they throw up?
Correct.
Did they pass out? Because a lot of people think anaphylaxis is when they're having trouble breathing.
Nobody thinks GI.
Nobody thinks GI. Nobody thinks to auscultate the lungs. They're always thinking, oh, they said their throat is closing up, and they're like, oh, anaphylaxis. That's the threshold. I'm like,
we have a similar in the EMS world.
Oh, you do?
Yes. That is a lot of people's
threshold. Their throat was tightening up. No. So I always ask these things like, GI. Pulmonary. So when you auscultate them, are they wheezing? So if you're coming into a home and they're like, they ate something and they broke out in hives immediately or something, or their lips are swollen, and the kid is there talking to you, if that kid is wheezing, and I always ask, like, does the kid have asthma? If that kid is wheezing, that's anaphylaxis. Right. You have the pulmonary system, you have the skin system, and then, of course, you want to get vitals too, right? They can be hypotensive. Those are the scary, scary ones. So if you are dealing with circulation as well, your circulatory system where they have hives or they have angioedema, and angioedema also covers the upper airway too. So if their throat is closing up and, they have hives or something else going on. I talked about the vomiting or they're hypotensive. Those are the ones that are really scary. And so you want to treat them accordingly. So I talked about GI, talk about pulmonary system, your circulatory system, definitely. Those are big ones. And then they can be really tachycardic. But I think that also can come with like them just being really, really anxious.
As well. Anxiety.
So anxiety.
But again, detailed history there too. Because if mom says or dad says or caregiver says, this happened once before, it wasn't this bad, that should be a trigger.
That should be a trigger. And I don't know what the hesitation is with giving epi. I don't they will give Benadryl like so easily. Be like, I gave them Benadryl, and sometimes it's definitely like it's been diagnosed. It's anaphylaxis. They'll come in. Yes, it's anaphylaxis. We gave Benadryl. Like we get the call. I'm like.
So I think that I actually have a partial answer for that. I think that's born out of the adult population, right? And especially the middle and accelerated ages, we use epi with caution, right? And so there's this holdback, and I think it spills over into that patient population unnecessarily, right? Where they're going to be the ones that are going to tolerate it the best, probably,
yes, they
right?
are.
Assuming non-chronic, right? Generally healthy, healthy kiddo, they're going to tolerate it the best, and also have the narrowest threshold for failure if you don't do anything about it.
Anything, and they can really come in shock. They really can.
And then the other part of that in my mind is, and we've talked about this on other podcasts here, is I think there's a misconception with Benadryl that it does something for the histamine that's already been released, and it doesn't do anything for the histamine. It only stops. It stops new release.
Yes, it stops new release. But you're going to have what's done is there.
What's done is killing them, right? And that's why they need the epi, and we should have a much lower threshold.
That always gets me, like you say too, when you get that anaphylaxis patient and the medic. Oh, we gave the Benadryl. And then yes. Well, no, the Benadryl made them better.
They could have done that at home.
They could have done that at home. And I always say, like, if you hesitate, and that's okay, and if this is a kid with no anaphylactic shock or they've had anaphylaxis in the past, I'm sure the parents have an EpiPen. That's something, too, you can use, like the EpiPen from the parents.
Just be cautious that it's within date if they've used it, because a lot of those might be very old. They're expensive.
That's true. They are expensive. Very expensive,
Same with the paper
breathing treatments, MDIs, Solumedrol.
What was your conclusion?
You up a good point about MDIs.
So the conclusion of the paper was...
I just want the last line, brother.
Besides overpriced pharmaceuticals, personal opinion, as to why parents don't replenish them, actually, is where my kind of focus went to.
Yeah.
It's expensive.
Was because if they purchase an EpiPen for their child and then let's say they don't use it in that expiration date, well, we didn't need it then, so we're not going to purchase it.
Correct.
And, it's a financial burden, and then there's a little complacency there. But I do like your point. And then the other thing, too, you talk about like EpiPen Junior versus everybody always refers to it in our drug box, not to go on an epi tangent, is, well, that's an adult EpiPen. And it's like, no, it's not. So at what weight can you utilize that EpiPen? Because let's face it, some of these kids that are into sports and they're working out sooner and they're becoming
kids.
more athletic, they're bigger kids. So, if you look at an adult EpiPen, you can use that on a child that weighs 66 pounds or greater.
Oh, definitely. So, there's actually a weight. I can look here.
So I think it's important to know that, because everybody, I think, gets that tunnel vision. Well, I only have an adult EpiPen, and I want to say it's 66 pounds, I believe, and that's off of Epis.
Very good. I'm impressed.
It's off of,
it's
Ray's our pharmacy guy.
It's 33 for junior.
So it's 33 to 66 pounds for the junior, and then 66 pounds and over, you're absolutely right, for just the epi. And so 66 pounds and over, exactly. If you have an athlete, a bigger kid, which we see a lot of 10, 12-year-olds, they can
playing
just get
sports,
the EpiPen.
they get active, maybe they get stung by a bee. See, I remember pharmacy a little bit, right?
Good,
but I think that's a huge point to make. And I also think to your point, too, on when we talk about anaphylactic shock, I think it's misunderstood a lot of times. So I know, like, Dr. Garlisi does the shock lecture, and I think a lot of us just get tunnel vision and we think, well, it's adults. Well, it's distributive shock in a pediatric patient, just the same as it is with an adult. And I always try to teach the reasoning, because everybody's like, well, should I think if you get to the question, maybe this would be a better way to say it. If you get to the question, should I give epi? You probably should. And then the easiest way to explain it is, I always say, this is a cheesy way to do it, but I always say, okay, I have a gallon of milk, and this is your container before you get stung by the bee, right? So I have a gallon of milk in the container. Now I pour it into a 5-gallon bucket. That's why I need to give the epi, right? We have to tighten up the vascular access to get them out of the distributive shock that they're currently in, and then I need to follow it up with Benadryl, and then let's talk about, maybe we could follow it up with 1 milligram per kilogram of Solumedrol on top of it. So it's like, and all these different drugs are going to do different things to impact the care.
I'm about to say
the fluid volume as well.
Because you need that volume, right?
Yeah, so
everything is leaky.
You're shrinking that 5-gallon bucket down at the same time as you're filling it up.
100%. We're going to make silk by the end of that. Transition from milk to silk.
Right. No, I agree. Like, when anaphylactic shock is bad, it's bad. It is shock.
Yes.
When it's bad. And I think a lot of times it's not taken as, I want to say seriously.
It's not attacked.
But it's not.
You need to attack it.
You need to attack it. And I don't think, Especially in the pediatric population, we don't. But we've seen some really.
It's even in the adults. I know of some misses.
We're gun shy on it.
A little bit, right?
Especially on epi.
And I think it's what did you do? It's like epi-Benadryl, sodium medrol, fluid resuscitation. I did it immediately, and they did it all at the same time, right? And that needs to be your go-to for it, right? And it's like, well, we did epi. And then we did Benadryl.
Some more Mountain Dew.
I pushed all of those. I did all of that in 30 seconds.
Right. But that's it. You when it's really that bad, you have to attack it. It's distributive shock by definition, right? You can't tool around with it.
No, and kids are more resilient with it. I like your theory with it there, and I think, Scott, you followed up too, is don't be gun shy. So if you think they need epi, they probably do, and then they're going to be more resilient with it. They're going to handle it better. It's not like you're going to harm that pediatric patient in that setting.
That's the old, if you have to ask, then...
I mean, that's good to know. So there's some hesitation in the adult population. I get that, but
Or if not, call medical control. I mean, to throw that out there, I think that's something we really work on in the pre-hospital setting.
And in the background of that phone call, she's going to hear, give the epi.
Give it.
She's just going to be across
Are you calling for epi? You should do that.
I don't even know what to call. Just give the epi.
The little ghost of Regina. Epi. And then epi.
An IV and give the epi. Yes. Don't be scared of giving epi.
We're going to walk out here with two things, right? Patient assessment triangle and epi. That's it. We're going to call this Regina's epi and triangle episode.